if I'm not mistaken, we have Serge Verstovsek on streaming, right?
Yes, hello. Hello, everybody.
Yeah, yeah.
Nice to see you.
How are you?
I'm doing great. I see you are doing great. I see a lot of people there. I appreciate you replaying the webinar. I think it was a great exercise and excellent communication between three of us to project the state of affairs of myelofibrosis therapies and what needs to be done. Where is the real medical need today in our management of patients that are slowly progressing or losing response over time. And I think that the distinction between the regulatory requirements and the real life is something that we highlighted well. And I hope that participants and listeners understand the rigor needed for approval of the drugs and then the later part to envision how that drug is going to be used is the completely different story.
We have about 30 minutes time for questions, and as I say, it's ladies first. I have Dr. Natalia Curto. She's here. She's from the Claire Harrison group in London, and I think she has some questions to you. Can you see her? I assume so.
I can see you, everybody. Thank you very much. Yeah.
You can hear me now. Is that okay? That better? Yes, good. Well, thank you so much, Professor, for this beautiful talk about POIESIS. And so many questions come to my mind, but obviously working on clinical trial as well, I think for our patients, sometimes it's really difficult, and I guess for the clinician as well, to take the decision when is the right time to put a patient on a clinical trial, why we should do that. And I think it would be nice to explain to the patients the difficulties going through, what's the criteria, all of these that we've been talking, because as Peter mentioned, obviously on that study you've been on RUX before, can you go that? So I think it would be nice to probably tell the patient how we select patients for clinical trials and giving a little overview on that, if you agree.
Yeah, this is a really good question. Unfortunately, and people will jump on that, even when we have a patient who is ruxolitinib naive, has never received ruxolitinib, and has a spleen that is big and causing problems, and has the symptoms related to myelofibrosis that are causing problems, and you would say that would be an excellent candidate for a clinical study, for this particular study that mimics the usual approach in the therapy in a community setting of patients with myelofibrosis. You start with ruxolitinib for 5-6 months, and then you see whether you need to optimize the care by adding another agent if you have any to provide. We don't have any approved in that setting. But even when you have a patient who would be possibly eligible based on these grounds, that patient also needs to have a good kidney function, good liver function, not to have another cancer at the same time, or not to be taking antibiotics for infection, because then infection is ongoing. What I'm getting to is there are eligibility criteria. Apart from having myelofibrosis, apart from having a spleen that is problematic, and apart from having the symptoms that are problematic, there is also a whole list of criteria that needs to be fulfilled for participation in the study. That needs to be conveyed to the patient as well. The goodwill from the doctor and from the patients to participate has to be taken into the reality of conduct of a clinical study that is not only objective and precise and demanding, but also in the light of the eligibility criteria that need to be fulfilled for participation. Testing for hepatitis, for example, or for HIV is usually typical to make sure that patients have no other chronic infections problems at the same time. So in that setting, then some patients that are willing and the doctors are willing will not actually become participant in this clinical study. That's another problem. You ask about the enrollment and eligibility in a sense, and that's I highlight because that's another distinction between the conduct of the clinical study, which requires uniformity, objective measurements, homogeneous population of the patients, and lack of those in the everyday management of the patients in the world. That's the important distinction that needs to be accounted for. So on the study, the patient also need to follow a certain path forward with the mandatory visits, not just the testing with MRI or the questionnaire that we said every 26 months. There is also mandatory visits to say, are you doing okay? Is there something else happening with you unrelated to the therapy or myelofibrosis? Safety is assessed, right? Dose modification may need to happen for one or the other reason. So participation in clinical study is a commitment from the patient and a huge commitment. And it takes time to satisfy the rigor of participation. Follow up once a month, sometimes every 2 weeks. Sometimes there is extra testing that needs to be done as a part of the clinical study. It is something that is hugely important for overall goal of the study to, in the best possible way, convey in the regulatory bodies what the risk and benefit of the medication is. That is the goal. Once we achieve that goal, then the approach might be somewhat different in everyday practice. I would say that participants, the patient's participation is extremely important and appreciated so much because of these demands on the patients to prove the value of the drug and possibly benefit from the drug earlier on than anybody else as the drug goes through this phase 3 study and awaits approval by the regulatory bodies. So there are two ways how you can look at it. Participants will benefit from the therapy if it's effective ahead of everybody else, but help everybody else as well to get to that state of approvability and a state of applicability in everyday life. So we work all together as a team toward that particular goal. Thank you.
I absolutely echo every single thing. I think, obviously, we work in large centers, and every time I approach a new patient with myelofibrosis or even, ET or PV, that we have now more studies coming, you have to offer that option, but it's a compromise. And it's a double benefit as well for us, obviously, our clinicians, to improve and provide better care, going forward, as you mentioned. So I think it's really important. But for the patients, it's a big commitment coming, as you say, sometimes every 2 weeks to our clinic, or even sometimes every week, because you have to monitor the symptoms and the blood counts. But I think it's really important to understand that the clinical trials and how that can change the future for us, isn't it? We have new drugs coming, new possibilities to make this disease chronic as we want. I do have an extra more question, but into someone else. But on the video, we saw a really nice discussion about, how we assess the disease. And I guess on the clinical trial, it's really clear. We do MRIs, we do symptoms assessment, but do you think one day we'll be able to transfer that to the real world day-to-day clinic? Probably not doing MRIs every 6 months. We'll probably be in a lot of trouble with our specific clinical directives in terms of money, but how we can change that, Professor?
That's a high bar. The cost that you highlighted is one. The availability. In many countries, there is no readily available MRIs to do them at will. There is a need to schedule patients many months in advance because there is only one machine in a larger city, for example, which I am aware of now that I'm participating and conducting this phase 3 study around the globe. So there are in practice not for the studies, alternatives to kind of give us a semi-intelligent way of addressing the issue of objective response assessment. Ultrasounds are usually readily available and can provide some very useful information in everyday management of the patients. But then I want to also jump to other side of the coin, and that's the quality of life assessments. This is where, as you heard Dr. Al-Ali on the call, this is the area where we as a physicians really lack any, I would say, I have to be harsh, we really lack any serious approach in assessing that quality of life of the patient's myelofibrosis. There are questionnaires that are readily available online or in paper format, any way you like it. They are mandatory for assessment of the quality of life in the studies, as you would suspect. Patient needs to answer them, but they can actually be useful in the clinic as well. And I would implement those if I am in charge across the board in clinics where myelofibrosis patients and other myeloproliferative neoplasm patients are cared for, to provide that patient-provided assessment of their quality of life, not assessment by the physician how the patient feels, but the patient's telling the doctor how he or she feels by filling the questionnaire. That will on its own enhance the quality of the care for the patients. If I think about something immediately that would improve the quality of life of therapy, regardless of the medications, is the assessment of the patient's proper assessment of the patient.
Thank you so much, Professor. I'm passing that to Peter. Some questions in here.
Hello.
He comes from Saudi Arabia.
Yeah, we met in Saudi, if you remember, Prof.
Yeah, hello.
All right, nice to meet you.
Nice to see you.
I have a question for you. Come here. Okay. So I have a question. Patient with polycythemia polivera, and they presented with Budd-Chiari, portal vein thrombosis, what we call Budd-Chiari syndrome. So there is thrombosis of the vein, which damage the liver and make splenomegaly, like large spleen, and also so the question, when they present initially with this changes, they will go to the hepatology, and then sometimes they do the JAK2 and they diagnose late after the liver got cirrhotic, damaged already. And some of them, they will go to liver transplant because of this problem, and then they come to me. My question to you, post-liver transplant, send anyone for bone marrow transplant after liver transplant, and if yes, how to do it?
Oh, very specific question. I'm sorry that this type of events actually develop in the myelofibrosis patients or MPN patients. PV, you said PV. That is one of the complications of uncontrolled growth of the cells and inflammation that comes from that disease. So clotting in the belly, the vessels between the spleen and liver can clot and cause problems, and that affects the liver function, and sometimes the liver needs to be replaced. I had now that you just asked me specifically about that, I recall a couple of patients that had a liver transplant before coming to me in my clinic in Houston at MD Anderson Cancer Center for therapy of myelofibrosis, and then were successfully transplanted in transplanted bone marrow. In terms of the management of a solid organ transplant and bone marrow transplant, there are some differences, but in essence, there is no radical differences, and it's possible to do the two, one after the other, in the expert's hands. So I always say that other medical problems should not prevent the optimal care of a patient's myelofibrosis, whatever it takes. And you would say the patient who had a liver transplant should not go for a bone marrow transplant is dangerous. Well, myelofibrosis is dangerous. So you're gonna then go and replace that bone marrow with a healthy bone marrow and eliminate one of the problems, and then maintain the patients on the medications to prevent the relapse, either the liver or the bone marrow, one way or the other, for as long as you can, and let the patients enjoy quality of life for a longer period of time. So one does not prevent the other, and it can be done.
Good. So also, if you allow another quick question, for those also patients when they have this splenomegaly, sometimes we observe them and we give, of course, anticoagulation, blood thinner, and later they may develop post-PV myelofibrosis. So usually we observe them if there is weight loss and if maybe the spleen become more hard. We do bone marrow. Sometimes the fibrosis in the marrow is in the gray zone, like 2 out of 3, for example, and there is no mutations that can say that there is a progression of the disease. Usually, how you deal with this patient? You keep the observation, you start earlier the JAK inhibitor therapy for them?
Sure, that's a really good question. The progression of the disease typically would be based, or judgment of a progression of the disease would be usually based, on a clinical grounds. Progressive enlargement of the spleen, progressive enlargement of the liver, progressive symptoms, weight loss, cachexia, bone aches and pains, night sweating. And that would be leading one to initiate the therapy if the patient had no symptoms or signs that I described, and they are now evident and they are causing patients to complain about the symptoms, or the spleen has enlarged and patient has a difficult time bending or has a pain in the belly. Presence of the symptoms is usually the key for initiation of therapy, and presence of a new enlargement of the spleen or worsening of the symptoms while patient is on therapy with a given drug, ruxolitinib, is a good indication to try to optimize that care so that the patient does not lose completely that benefit. Or in some instances where there is absolute loss of a control of the signs and symptoms with a given drug, perhaps ruxolitinib, then that's a time to change to another agent, another perhaps JAK2 inhibitors that are now approved. The bone marrow progression is more of an issue when there is an increase in a blast, the type of white cells that is a baby cell that we all have in the bone marrow, up to 5%. Everybody has up to 5% of blasts in the bone marrow. They usually mature and become normal, mature white cells, red blood cells, or platelets. They can be seen in the blood of the patient with myelofibrosis because the fibers in the bone marrow basically pushes them out. And if you see increase in the blast percentage-wise in the blood of the patient with myelofibrosis, higher and higher and higher percentage, then I would advise the bone marrow to look for a possible progression to acute myeloid leukemia that is seen in about 20 to 25% of the patients. Otherwise, the great majority of the patients really progress on a clinical ground rather than a bone marrow progression.
Yeah.
Now, I would very much like that our patients that I hope will have also some questions. And you, John, will break the ice. Please go ahead.
I'm John from the Netherlands.
Question
about your trial design.
I can't really hear.
Hello.
Hello.
Oh, this works better. I'm John from the Netherlands. I have a question about your trial design. If I understand the workings of your medicine well, it could be used without ruxolitinib as well. So my question is, why is it following up on a ruxolitinib treatment and then on top of ruxolitinib? And why isn't there one arm at least where you exclusively use your own drug without ruxolitinib?
Very good. Thank you very much, John. In the prior studies, we have studied navtemadlin alone in patients who have tried JAK inhibitors in the past and became resistant or refractory to JAK inhibitor. In that randomized study, we compared navtemadlin alone as a single agent. We compared it to other medications that the doctor wanted to try. We call this best available therapy. So it was a randomized study in patients who were previously treated with the JAK inhibitor, were resistant, refractory, and then these patients were randomized between the navtemadlin alone or a best available therapy, whatever the doctor wants to do. And it showed significant improvement, and I would say in a simple way, there was a tripling of improvement in the spleen between the navtemadlin and the best available therapy, and there was a doubling of a control of the symptoms versus best available therapy. That was presented to the public about a year ago, which proves the point that you are bringing. Is this drug active on its own? Yes, it is. However, for the possible approval, we had to choose a study that would possibly shows the best benefit of navtemadlin and answer a need. Me as a physician and now Chief Medical Officer of Cartus would like to not wait for resistant or refractory situations to JAK inhibitors. I want to intervene earlier on. And where better can I intervene as a physician than say, okay, you are better to some degree with the JAK inhibitor. Can I optimize your care? I don't want you to be resistant, refractory, or stop your JAK inhibitor. I want to add something to it. And that's how we came up with the suboptimal responder term, which hasn't been used that long in the past trial designs, and say we want to identify patients that are in medical need for optimization of the care and not wait for them to be resistant or relapsed. Give them a chance to be optimal in their response and then live with the two medications, taking two medications for as long as possible.
Hi. Hello, my name is Dolf. I have a question. I would like to fast forward a couple of years, and the drug has been a success. The people with MF are living the life they want, but there's only one cloud still above their head, and that's the morphing from MF to AML. Do you think this drug also will decrease the chance of morphing MF to AML?
Excellent thinking. I really love that thinking proactively. What can we expect down the road? If we are, as we are, seeing the biological modification in all these parameters that I explained that are related to the clinical benefit, you can easily connect the decrease in all these parameters, CD34 cells, cytokines, and all of these other ones, with improvement in the symptoms, with improvement in the spleen. That can all be done, and it's out there to talk about it. Is this going to be leading to less of a progression to acute myeloid leukemia, or even lead to prolongation of the survival? Well, the answer will hopefully come from this study. POIESIS study has an immediate goal of assessing the spleen and symptoms response after randomization, 6 months later, right? Patients are randomized, placebo control. 6 months later, you have MRI and a questionnaire, and you see whether there is benefit from navtemadlin. However, we're going to be following those patients for as long as we can to address the issues of, are we able to decrease the progression to acute myeloid leukemia, or are we able to make people live longer? So it's a part of the study.
Hi, good afternoon. I'm Simon. I'm from the UK. I'm a patient. I've got MF. I haven't taken Rux, so this is like, oh, interesting. You've talked earlier about kind of having a problematic spleen. As a patient, I don't really know what that means. You've talked about kind of troubles bending over and stuff. What are the thresholds and the criteria to get onto this trial? Is it a bit more explicit than a problematic spleen? Because to me, that's a little bit opaque.
This is a really good question. When the patient comes to the doctor and the doctor would ask the patients, how do you feel? And perhaps some other more specific questions. Do you have abdominal pain, night sweating, itching, bone aches and pains? Are you losing weight? And the doctor would possibly palpate the spleen on the lower left side here, below the ribs on the left side. Then the doctor would be typically assess the need for intervention based on his or her judgment, right? Patients telling the doctor, hey, I have a pain, this and that. There is no scale, there is no MRI. It's talking and examining old-fashioned way. That's how it goes. Then the doctor says, you are sick enough. You have symptoms. Let me treat you. I'm going to decrease your spleen. You don't have that pain anymore that bothers you that you're telling me about, or the itching will go away because you're telling me about it. It's problematic. For the study, we utilize the questionnaire, which has been developed and validated for use in a clinical study. It's a 10 question questionnaire which summarizes 10 most common problems that, or symptoms, sorry to say, that patients with myelofibrosis experience. And each of the 10 is graded from 0, none, to 10, the worst ever. And that is given to patients to fill out, and you calculate the score. The score can be 1 to 100, right? And if you have more than 10, or to be precise, 10 or more, this is where this is judged to be clinically relevant or bad enough for participation in a clinical study. So there is the objective way to it, from assessing from the patient's response to a questionnaire how bad the situation is for the patients. And then, of course, the goal of therapy is to decrease that score by 50%. If it's not 50%, then it's suboptimal. Hopefully that helps.
Yes, yes.
Hi, Sach. This is Rao here from Switzerland. A great talk, and thanks for having a nice discussion. So my question to you is that you're aiming to target to improve the wild-type P53 function, right? So what about patients with the P53 mutations? Because you often see that at the late stages in the myelofibrosis to the secondary AML. So do you also consider those patients in your trial, or how does it work in that case?
Really good question. So for us to reactivate the P53 activity by blocking the MDM2, that P53 protein needs to be normal, right? It's just dormant because there are too many MDM2 proteins. So we block the MDM2, we inhibit the inhibitor, and the P53 is awakened again and starts working. Well, what you're asking is, what if that P53 protein on its own is mutated? 2 to 4% of the patients with myelofibrosis in a chronic phase, we are taking patients. And we actually test the patients before they are given navtemadlin. We give them, or we obtain a blood sample from them to test for a presence or absence of the mutation. And I'm sorry, I'll just move a little bit. We then exclude them from the navtemadlin part. Mutation to participate in navtemadlin because it's not going to work. The P53 is mutated. Did you hear me well?
Yeah.
Hello. Yeah. One more question, a bit off topic, but I was just wondering. We see in our data, we are running an app where people log lots of information, including the question, does any of your family has MPN? And we see a really high number of patients where there is MPN in the family. And we all know that the mutation is being acquired during life. So the mutation itself is not inherited. But could it be that the MDM2 effects are the cause of familiarity and getting this from inheritance?
Well, that's an interesting question. I never heard of anything like this. I have to admit that there is any connection between the MDM2 and inheritance within the family members. What we know is that that's a consequence of a presence of malignant cells rather than a cause for it. So I can say yes or no because I never heard of anybody doing any study to look into it. But from what I know about MDM2, I would say that is highly, highly unlikely.
Okay, Serge, thank you very much. I think...
It was a pleasure. Thank you so much for having me.
Yeah, thank you very much.
Thank you. Have a good rest of the day. Bye-bye.
We have a very interesting presentation, and I know people likes it very much. Enjoy Rome, yeah?
Bye.
Bye-bye.